Thank you, everybody. Thanks for joining us again on this dreary evening. Adrian and I back in clinic again. Today is a bit of a general sort of chit chat, but at the same time, we're going to try and do some practical stuff. So hopefully there'll be some learning points for all. We're open to questions completely, as Steve said. So pop out as you go along. What we'd maybe like to do is try to get you to focus on whatever we've covered over the last 8 or 10 weeks. And we're very happy to recover that. So anything to do with the foot, ankle, knee, what else we do? Shoulder, and hand.
And hand, yeah.
So any questions relevant to that or imaging? We're going to cover some knobology today. And we're going to kick off with a little practical demonstration. I'm going to shortly take my screen onto the scanning screen. And I'm going to try to show you the plantar fascia. And we'll set the ultrasound up to get a nice image. And then what I'm going to do is cock up all the controls, mess up the image as much as I possibly can, and ask Adrian to turn away. Then I'll ask Adrian to turn back and try to show us how he's going to adjust the image and try and get it nice and clean and sharp again. Just in the event of, I mean, it used to happen a lot more. Nowadays with presets, it's not so difficult, but just say, for example, you've walked into clinic, switched on your machine, and you just can't see anything. This is how you might get out of that situation. So let's see how we go with that. Pop your questions along the way, and we'll see how we go. Once we've started with that, we'll talk a little bit more about the detailed controls, and we'll probably just mention a little bit about terminology as well. So let's kick off. First of all, I'm just going to switch my screen over to the ultrasound image, so bear with me one moment, please. Let's switch to the MSK setting. Now you can see our picture. You can just see my little thumb hover along the side, so I know where I am to orientate myself. Let's find our plantar fascia. Okay. Right up. So we can see the calcaneus there, right at the bottom of the image. You can see the plantar fascia laying over the top. And you can see the soft tissue in the fat pad and the dermal layer. So that is a nice textbook image. Okay, so that's what we should see. Okay, so let's ask Adrian to turn away. And if I just turn the camera, before you turn away, sorry, Adrian, can you turn the camera to the knob so everyone can see what I'm doing here?
Maybe that way.
Okay.
I can't see the screen, so
that's fine, you turn away.
Can you see the keyboard, Steve?
Sorry, I was on mute then. No, sorry, I can't see the keyboard just yet. 1 second. Try that again.
Oh, okay, it's that way. There we go.
Right.
There you go.
All right, well, I've done my bit. Now you can see I've got my probe in the same place and you can't see anything at all. So, Adrian.
Oh my God, what's he done?
Let's have a look. There is one simple and easy way to do it, obviously, that everybody will probably guess, but we won't talk about that. Let's just see what we do with the imaging control panel. So just talk us through what you're doing there, Adrian. What you're thinking about adjusting.
Right.
Why don't we, can I just interrupt? Why don't we see if anybody on chat's got 1 or 2 seconds?
There's an idea, yeah. Any suggestions from the audience, please?
They are, that's making sure they're paying attention.
That'll liven it up, won't it? Yeah.
Yeah.
All right. Anybody want to make a start? What should we be thinking about doing? We can, as I say, do an easy version to cut everything out, but have a think about where we are and what we're looking at and how much we can actually see on the screen there. So what I can see on the screen is very little. I can see a very small, tiny, narrow window. It's not taking up the whole screen at all. So maybe the first thing we should think about is are we at the right depth? Because you can see the depth gauge is showing there.
And also, it was a bit like this, so I wasn't sure, we haven't really got an image there, so what I'm going to do is I turn the gain up, and that'll give me some indication of what's going on.
So we have a miniaturized plantar fascia.
There you go.
Okay, but at least I can see it, and at least I can make out the features.
So that's with the B gain, that's what that's called.
B gain.
Yeah.
Yeah, so that takes down the brightness or the darkness of the image.
Okay, so then what I do is, because we've got that really tiny narrow window, we need to widen that up. So therefore, I go to this button here, which is the depth And there we go. I'm just twisting that, and you can see that getting bigger. There we go.
There you go. Filled up the whole screen with a nice clear image there.
So I'll go back one. So that's that. And then if you see the little red triangle, that's not quite over the plantar fascia. So I then bring the focus, which is up here.
And what is the red triangle for, Adrian?
So that's showing you where the focus of the ultrasound beam will be most concentrated. So if I have it right down here, it's going to be most concentrated down at the bottom there. So I need to bring that up to the level of what I'm scanning at and what I want to look at.
That looks nice and clean and clear. Is there anything we can do to clean up the layers a little bit to help to bring the plantar fascia a little bit out of the image?
Yeah, so what you can do, you can see we're on, if I point up to the top here, if you read up here, it'll say 610. So that's the frequency. So we want the best frequency we can use. So I'd take that up to 17 and maybe just turn the gain up a little bit. And that gives you the best, the highest frequency, which should be the best, best scan image.
Is there another way to clean up the layers a little bit? Maybe
you can
TGC controls.
Oh yeah, I can see you. See, so what Abid's done here, he's moved the far gain all the way down. Now that's this portion here, that's all black. So if I bring the far gain up, you watch your screen, you'll see the brightness filling up the bottom of the screen. Now I've pushed it right over here to make it to emphasize it. You can see now we've got image up here, down here.
And if we turn the TGC controls down again?
Yeah. And you can see on the right, there's that arrow, that yellow line, sorry, that's just showing you where I've got. So if you look, I just have to touch it to that line to come on. See how it's narrow at the top and then far away at the bottom. That's because the sound wave's getting attenuated as it goes deeper. So you need to increase the gain at the far field, which is this here, because the sound loses energy as it's going down, so it's getting attenuated. So you increase the gain in the deep far field to even it out.
Yeah, and that's one part of the controller that I think we should all keep a little eye on, even though we have the presets, because these are controls that can easily get knocked or budged as you're moving your machine around and your cart around and getting around people. You know, how many times I've come over and, what, this can't, hang on, my presets are okay, everything's okay down here. Why is my image not nice and clear and showing me the different layers? Well, it's very easy to just nudge these out one way or the other. So always check your TGC controls, and I think you can get them to your own sort of individual eye.
Now there are other things that you can change as well. You've got the trapezoid, which will give you just a little bit of an extended field of view. So you can use that. You've got compounding. It's got, I think, let me change that. It's on the highest, I think. And then PHI, I think that might be harmonic English, just called something else. You've got obviously the focus, frequency, and I think that's pretty much it. You've got the panorama as well, which means you can stitch the image together and make a long picture, like we showed you. I think last week we showed you where you can stitch the images together and create a longer picture if you want to measure something a lot larger than the actual screen.
How about a really common one that I find really useful and people don't always remember is being able to compare. So how do you compare two images? I want to compare the right plantar fascia with the left plantar fascia on the same screen to help me to make my diagnosis and to show the patient what's going on. Okay,
so I'm not using it on this machine, but let's have a look. I think this is probably it here, which is dual screen. So if I press that, let's just see if that does it. Yeah. So you've got now two images side by side.
So I'm just going to pretend I've taken my probe off and I've put it on the right foot and I've got that image there.
Yeah.
Yeah.
So therefore, if I press the other one, it'll flip to the other one. I just press that again, and it's flipped to the other side, and then you can put it on my right foot and compare.
And then how do we freeze both frames?
Just press freeze.
Thank you.
And now we've got both next to each other. Obviously, they're both the left here, but you obviously swap it to the right, so you compare them.
And can we now take out the calipers and compare both sides?
Yeah, we can. So caliper, which is here, click on that, and then you can move across, position your caliper, press select, move it down to where you want to measure it to. On a slight angle here, it might be wrong that. Do one, and then do the other.
You can see underneath number 1, number 2, very easy and clearly laid out, and you can see the difference in the thickness.
Yeah.
Yeah. Nice feature. Very nice feature in ultrasound.
Yeah. So, and then you just press that, and it goes back to single, which is that one. It looks like you can do 4 as well. I've not had that before. There you go. You could, if you really wanted to compare 4, you can compare 4. Transverse and long section on both sides, maybe.
Of course, yeah. Okay. Any questions there so far? Okay, what I thought we'll just talk about next for a moment then is what's the difference between colour flow mode and power wave mode? And when would you use one for one and one for the other?
That's to me.
That's to you, yeah.
That's to me, sorry.
Just have a general chit chat about it for the audience.
Okay, so colour mode. Let's put colour on. Let's go through it.
Yeah.
That's it. That's it. Okay. So we've got the box on here. You can see in the top right-hand corner, you've got the box. Now the red's on the top and blue's on the bottom. Now that's conventional. Sometimes you may put it on and someone's flipped it. So always look to which one's on top. Red should be on top because that's convention. So you remember the term BART, B-A-R-T. So blue away, red toward. Okay. So anything you see in blue is blood flow away from the probe head, and anything you see red is toward the probe head. So just by angling your probe, you can make a vessel fill blue or fill red just by how you angle it.
Let's just show them that. Shall we show them the medial ankle while we're talking about it? There's some,
yeah.
Show them some flow.
Okay.
So we've got your.
I'm just going to turn the
neurovascular bundle right here.
Okay. So you can see.
I just need a little bit more jelly, not got much there. Okay, and then there's another good point actually. If you've not seen your image properly, look how what a difference that made just applying the right amount of gel.
Yeah, absolutely, yeah. So I'm going to take this up a little bit.
So you mentioned sometimes somebody might have flipped the bar around, the colour bar.
Yeah.
If that was the case, how would you go about looking at it the right way around?
Oh no, that's I'll have to find that on here. There'll be it's on most machines. It's called invert. I don't know what it's called on here because I've not. Oh, there it is, invert. There you go. So sorry, let's show that. So that's invert there. It says invert, and now you'll see the red's on the bottom and the blue's on top. Okay. So when you want to know the direction of blood flow, then that becomes important.
What would be the benefits of switching the two? That's not a stupid question.
Well, some people just like to, some people just have it their certain way.
Okay. Just personal preference.
I don't know, to be honest. I don't know why it's allowed. Why it's allowed to switch, because convention is always red toward blue away. It baffles me to why you can switch it. I'm sure there's probably a reason. But that's convention. Now let's partly that was power, wasn't it? So power is independent of direction. So
let's clear up another little argument, because I always get asked this question: Is this vascularity? If you put it over a joint on CFM mode and it's showing activity, Is that showing inflammation?
No. So if can you see that box at the moment? There's not much activity, but if Abid was to wiggle the probe, yeah, that's all flare. So that's picking up motion. Okay, so that's all artifact, all that you can see. So I mean, you have to make sure that your gain's not set too high as well, because you can see at the bottom there, that's all flaring out now. Okay, so so you just turn your color gain get down until you get rid of all that. Okay. So any movement will create that artifacts, but you can see that.
I find that's common on manipulating gain
Yeah.
through a study.
Yeah. So that's what you want to do. You want to bring your scale down. You can bring your scale down so it's picking up very, very low velocity flow. You can see that whatever movement he does now, that you pretty much picking it up. But if I take the scale up, you can see those numbers going up. It becomes less and less sensitive, almost to which you could say, okay, there's no flow here. So hold on, what's going on? He's got no flow. But it's probably because you've got the scale too high. So you need to bring the scale right down until you start to see stuff happen. And there we go.
Or you've got too much pressure on your probe.
Yeah, exactly.
Yeah, so I've totally, I can squish that right down to almost nothing. I can take the pressure off. So that's not applying very much pressure at all. So again, just reiterating the light touch.
Now the other thing is, when you're doing studies with the Doppler, and we don't do much Doppler in MSK, to be honest, so, but we'll go through it. If I alter the size of the box, so if I have the box right, very big, you might think, okay, that gets everything. But actually, if you look at the image, it's slowing it right down, making it very laggy. Okay, so that's called frame rate. So that's really reducing your frame rate. So what you need to do is bring your box right down to where you want to see, and then your image will speed up a bit, and you won't lose that lag in time.
Okay.
That's more real time now.
Yeah. So you can see with movement, you get all that flash artifact, but when you're really still, all you get is hopefully just the vessel. There you go. And those are veins either side. So it's probably going really slow. Now, if I squeeze my calf,
Can we just see where the probe is at the moment then? Do you mind?
oh, sorry. So just
So I'm kind of diagonal between the medial malleolus and the back of the calcaneus. Slightly oblique. To pick up that neurovascular bundle.
yeah.
Yeah.
So just going back to that image, you can see that there's no flow either side of those veins. But if I squeeze, so this is how you check for DVT.
Yes.
So you squeeze and you get flow. Okay. And also you can test for DVT by compressing. Okay.
We have got a question around the power Doppler. John's asked about when would you use the power Doppler rather than the colour flow Doppler?
Well, I tend to use power Doppler in MSK more than the colour Doppler, to be honest. So I'd use it in rheumatology when I'm looking for synovitis. But you need to have your settings set really low down. Colour flow is not as sensitive as power Doppler. So I tend to use the power Doppler just to pick up that real subclinical synovitis appearance in the joints. So that's when I'd use power. So it's effectively, it's more sensitive than the colour, and it's independent of direction. So it'll be orange no matter how you angle your probe. So picking up inflammation, basically, tenosynovitis, synovitis, things like that.
You may have covered this, but how does one optimise the power Doppler imaging?
So same way, really. So I think on here it's PDI, power Doppler imaging. So you just press on that, that goes orange now. So same sort of thing, and then you just bring the same. Let me just check this. Is that the colour gain? I think they're both the colour gain. So you just take the gain right down until you just see flow in what you want to see. Okay, so I've taken it down, right down now.
All
So
right.
then I just tweak it up until I see flow, and that's optimised now. There you go. That's optimised. There you go.
Thank you. John, come back to me if I've not covered all of that, but John has got another question. Mark, I haven't missed your question. I will come back to that, but I'm staying on the Dopplers at the moment.
They like the Doppler, don't they?
No, I think it does come up commonly. There's a lot of it is difficult to differentiate between the two, so it's not always I think it's a good point worth covering.
Yeah, absolutely.
So how can one tell? Here's another question on it. How can one tell if they have the power Doppler imaging a blood vessel rather than a hyperemia? I'm sure I've said that wrong. In an injured tissue, can one tell by the pulsation?
Well, if you've got hyperemia, that'll be sort of within the tendon or around the tendon sheath. And if you elongate it out, the vessel will tend to carry on, at a good portion of length. Whereas hyperemia will tend to be little short, little bursts of orange flow around the particular area. So once you see enough of each, you get to differentiate what's vessel and what's hyperemia.
Okay, come back to me, John. If you want any more clarification around that, but thank you for your questions on that. So, a particular question from Mark a bit earlier. Let me go and find it. Any tips for finding and viewing the ATFL?
So the ATFL is on obviously the lateral side, so we'll just shift over.
Yeah, we didn't cover that in the lessons because we wanted to do lateral and lateral ankle separately.
Now it's best in sort of a dorsiflex but sort of inverted appearance, and then I usually use the 3 o'clock position from the lateral malleolus. So that looks like it there. So let's focus up. Oops, the way. Okay, you can see.
Just apply a little stress to it.
Yeah, and you can see that black band going across there. That would be the ATFL. There's 2 fascicles to the ATFL, there's a superior and inferior fascicle, but difficult to see the inferior one.
Yeah, well, when we come back after the summer sort of break and the next bunch of programs, we're going to cover lateral ankle in a lot of detail. You know, we're going to show you perineals. We'll show you how to pick up the ATFL, CFL, ATIFL throughout the lateral ankle.
Well, we'll do a particular meeting on that one specifically. Brilliant.
Yeah, we'll show you a whole hour on lateral ankle. There's your perineals, just for example, brevis and longus.
And you can just see under there is actually the CFL.
Yeah, little hammock as you come around. We'll show you a little nice couple of tips and tricks with this. You know, you can how to pick up that little hammock of a CFL as you're passing underneath. Yeah, you can see a nice halo around the tendons there. But we'll do that in another program if that's okay, because don't quite want to cover it today because it's going to be nice and new and fresh for everybody. But at least you get a bit of an idea. I mean, it's a lot to do with positioning.
Yeah, and it's a lot better to do it hands-on because you do get the sense of the feel and things of it there.
And it's just angling and clock facing. So we'll come up with a bunch of tips and tricks for you for this one.
Okay.
All right. Should we talk a little bit about? I thought while we're there, let's talk a little bit about descriptions of anatomy. So I thought if we just look at the Achilles tendon and let's talk about what the difference is between heterogeneous, homogeneous.
Yeah.
You know, all that sort of stuff. So let's first of all, we've moved to a different part of the body now, part of the foot. Let's re-optimize our image. So You want to talk us through what you're doing there, Adrian, to get a...
So I've just decreased the depth a bit just to get a...
Tricky.
Yeah.
There you go.
Ideally, I tend to have the patient prone.
Yes.
And then instead of coming from underneath where Abid's coming from, it's quite difficult.
It's difficult because you've got to hold your probe up with
Yeah.
pressure and keep the pressure on, whereas if your patient's the other way around, you're just letting the weight of the probe do the work. So it's really easy to just slip off, and of course it's fractions of millimetres to change your image completely. As I'm showing you here, actually, if we go from a nice optimised sort of looking tendon, and if I just come off very slightly and veer around the lateral side, you start to see a very different picture. It looks thicker than it actually is.
Yeah.
So let's get a bit of the calcium view, and if you want to maybe just freeze that, then we'll do a bit of knobology with it.
Yeah. So where's my pointer? I think it's so. Did you want to go to terminology first?
Yeah. How would you describe the, we'll talk about echotexture and all that sort of stuff.
So
if you've just scanned this Achilles tendon for a patient, how would you describe the image that you're seeing right there?
Okay, so we've got a nice hyperechoic bony contour, bony surface here. So that's hyperechoic.
And I'd say that's regular as well.
Yeah.
Because you do get these calcific changes in sort of aged people, and then you'd comment that it would be an irregular bony cortex. And
I'd call this a sort of normal homogeneous fibrillar pattern. So there's not loads of dark spaces and bright spaces. It's homogeneous. It's pretty uniform throughout.
You should be able to make out the striations all the way.
Yeah, so see this little fibril here. So that's the fibrillar pattern that you're looking for. So you're looking for a nice fibril pattern to the tendon.
I sometimes say normal echo texture.
Yeah.
You've heard that one.
Yeah.
Similar sort of meaning. So is it? It's about saying what you're seeing in whatever words it takes for you to describe it.
Yeah. So all this is all. There's no ultrasound down here. This is all anechoic because of the bone.
Anechoic meaning dark area.
Yeah.
Hyperechoic meaning nice and white and bright.
Yeah. So this here. So here, let's say, I'd probably call this hypoechoic. So it's dark. This down here, I call anechoic. So there's no echoes. So when it's anechoic, there's no echoes. When it's sort of dark, but there is some echoes, I call it hypoechoic. But it's relative to what you're looking at. So if compared to here, that is hypoechoic to this, because this is hyperechoic.
Would you be tempted to call that a bursa? Because if you look, it's got some slightly. Everybody's seen the image. We've got some slightly odd shape here, haven't we? But it depends on the moment in time when we've frozen it, of course, as well.
Yeah, I would probably think this is probably more artifactual. Bursa, you tend to see a bit of more of an anechoic fluid layer here, and then it sort of comes down. I'd have to probably re-optimize that and just make sure that that's not. So if I take that off.
So call that sort of Kager's fat pad area. So you shouldn't really have an anechoic area in there. So we'll just scan over and across.
And what I'll do is I'll bring the focus down, and you see already, just by doing that, it's made it a bit brighter.
You can even see the echo texture in the tendon is more fibrillar pattern to it.
So again, remember, if your settings aren't right, so if you've got your thing right up here, all that's going to look dark down there. So optimise your settings. Sorry, Steve?
Sorry, I jumped in mid-sentence there, Adrian. You carry on.
That's all right.
Oh, well, I was just going to say, while you've got that back to a live image, could you go over determining the hyperemia on the Doppler versus the neovascularization within the tendon?
Time
to do it?
Let me see. I don't know what you're not quite sure. Wait, so I'd put the box here.
Yeah.
And I'd look for hyperemia. Now, it's not going to be a very vascularized area, this anyway, but when it's inflamed or hyperemic, it will be. So is that what you're after? Just
Yes. Well, are they looking for a tendinopathy and how to distinguish tendinosis from tendinopathy or something like that?
I'll give them a chance to respond.
Tendinopathy, I would tend to be thickened, dark tendon. As soon as I see hyperemia in that tendon, then it becomes tendinosis. We tend not to use tendinitis. They don't like tendinitis. Call it tendinosis. I think that's what you're saying, Steve, about that. But let me know if it isn't.
Okay. Yes.
I mean, if you've got a true rip-roaring tendinopathy, there's a heck of a lot of activity there.
Yeah,
you know,
yeah.
you'll see it'll look like Christmas.
Yeah.
You know, the flashing lights will be going absolutely nuts. You'll see swelling in the paratenon. You'll see usually fusiform thickening around the tendon itself, almost like sort of scar tissue kind of building up around there.
Yeah.
And it'll just look real funky. This is a nice, anatomically correct bit of a tendon that you're looking at. But you can't actually. Some people you can see a real nice layer between the paratenon as well. We can't.
So,
yours is there, but it's some people it's real big. And you can see that little artifact I've got in the middle of my image. You know, there's a little, that's it. Yeah, and that's not anything to do with the settings on the ultrasound. That's again lack of jelly.
Yeah.
So I'm just going to reapply for a second.
So whenever you see hyperechoic area within your tendon or whatever you're looking at, just follow that hyperechogenicity, both outside of where you're looking and down, mainly up here, because you can get shadow casting down. Whether you might have something up here that's casting a shadow down, but you might think, okay, that's tendinopathy. But it won't be. It'll just be the shadow cast down from something up above. And if you look, actually, as I'm moving,
cool, yeah, look at that little bit of tissue moving.
As I'm moving here, it just goes to show you that ultrasound's dynamics, and move things as much as you can, and it will tell you what's going on. Maybe a little bit of.
I've seen a few tears that looked like they were kind of there was kind of fluid layer in the tendon. Yeah, and when of course fluid, it's messes up your image a bit, and it can confuse you and fool you to you might not think there's a tear or a rip there because you can't quite see the frayed ends sometimes, and you have to really squish the fluid out of the way to really get a good view of the actual tendon itself, and then you'll really see the splits and the tears in it.
Yeah. And if you do get a tear in the Achilles here, you sometimes get Kager's fat bag herniating into the gap, so just be aware of that. And that sometimes requires surgery because they sometimes can't get the fat out, so it just disrupts the healing process when you get the fat herniating in. So you have to document that if you see that within the tendon.
Yeah, and then don't forget it's a three-dimensional structure as well. So sometimes you get pathology on the upper third of it, and sometimes you get it sort of on the anterior edge of it.
Yeah.
And also, obviously, don't forget to go onto your trans view of it.
Yeah.
And let's talk about how we put. So that can be difficult.
Feedback. Yeah, that covered it. Thank you. I think the takeaway point there is we will look for Christmas.
Yes. Yes.
Coming.
When you hear Santa's sledge coming.
Yeah. But make sure you've got the settings optimized, because if you've got your scale too high, is it too high or too low? Too low. If it's too low, it will look like Christmas because it's picking every slight little movement up. So just optimize your image before you start calling it Christmas.
Here's a nice little view. Can you see that little defect on the left side of the screen in the tendon here? And look, you might be filled to think that's a little tear. Somebody who's got pain in the Achilles region. So how would we call that? How would you try to improve the image of that?
Well, before you start calling,
is it a blood vessel?
Yeah.
Or what? What is that?
Well, if I suspected a tear, I'd always confirm it in two planes. So I'd look at it in that, and then I'd try and turn right on it. And I think that's probably just.
Yeah, you can see it there, but see how that could be. You know, you might be fooled into thinking that's something.
Yeah.
Should we put colour flow on there and see if anything pops up?
We could do that.
Is it a little blood vessel or something, or?
I think that maybe just the Palatina, maybe.
Normal, yeah, it could be just the Palatina, but not quite in that view. So would that give you any cause for concern if you were in a symptomatic patient, that little defect? I mean, is that what you'd see if you saw an Achilles tear in a trans view? Would it look like something like that? Intrasubstance tear possibly, or is that more of a C shape always?
It's difficult to get across what is and what isn't until you see enough of them. I probably wouldn't call that.
You can't quite squish it away. If I apply pressure, it doesn't do anything. I mean, this is on the sort of undersurface of the tendon as well.
Yeah. I guess it's symptomatic and maybe looking a bit harder, but I think it.
Well, yeah, if you look at actually, you can see some of it looks like a little pepper pot sort of appearance, doesn't it, around there?
Yeah.
Have you been very sporty in the past?
You wouldn't know it, but yeah.
This is honest. Yeah. But it kind of looks a little bit peppered there, doesn't it? So you could be. Some people could think there's some pathological.
Could be on the way out. You're right.
I think you've had it, mate.
Yeah.
Ready for the neckers yard.
Yeah. I'll go and step out.
Yeah. But look at the difference up here. You know, much nicer architecture. But we've still got those little tiny defects up there. But not something we're worried about if we flick into. I mean, it looks a little bit sort of a little bit dark in areas there, doesn't it?
Hold on, let me just. I haven't got the focus up there.
Are we on the right frequency, do you think?
We're on the highest, so.
All right, but yeah, there's some good stuff there. Any questions there for us, Steve? Anything anybody would like us to cover? Any other anatomy or body parts?
Nothing coming since. I'll encourage everybody. Oh, here we go. Here's one. Just in time. Whilst in the area, how do we distinguish plantaris?
If you've got one, not everyone's got one. It's on the medial.
Not easy to see once you rupture your tendon.
Yeah, absolutely. Yeah.
Sure.
So it's on the medial aspects. It's probably best to find it in transverse. There's an arrow. So is that medial here? Yeah. So it's quite difficult. There it is. That's probably it there.
See, so shall we show people where we are on your foot? So I've got my probe. So I'll pick up the Achilles. I'm going to get you back in the middle. I'm just going to rotate my probe medially slightly.
You can see actually there, look, it's dark at the moment, but that's probably.
So going down.
It's a little bit of artifact coming off the edge of the tendon.
I can bring you back in the middle of the picture.
So yeah, it looks like, I think that might be it there. It looks like that's how it looks, but it is a lot easier to see when you actually rupture your tendon, because when you rupture the tendon, it looks like there's a perfectly linear tendon within the Achilles, and you think, oh, the Achilles is still intact.
Yes, caught me out many a time.
Yeah, but it isn't. It's just the plantaris has just migrated in a little bit. So if it looks perfectly linear and the Achilles is ruptured, then it's not the Achilles that's still intact, because that's the plantaris. So yeah, that looks like it just there.
Come back towards the Achilles. You just see it sitting in its own little hammock there. Right next
what about on long axis?
Yeah, you can go on long axis, but as you say, it becomes very difficult because obviously you can slide straight back onto the Achilles. So, good job.
Testing my skills, man.
As the Americans say, good job. So
don't get me started. Every time we do these things, I feel like breaking into an American accent. I watch too many YouTube clips myself.
So there we go. That's going up there. And then you could follow that all the way up.
Yeah, I'm going a long way, but
Yeah. But it's better when you're prone,
Yes.
because then you can be on top and follow it nicely up. And there's a technique which we can show you in the hands-on. Oh, you can't see because I'm. So you use your fingers as a guide up the side of the side of the leg. So you're holding the probe here, and you guide the probe up the side of the leg using your fingers as a guide. So you sort of going like this as you're moving the probe up, and that keeps the probe nice and still, so you can follow things easier. If you just hold it on, you're slipping and sliding all over the place with the gel. So you use your fingers as a guide, hold the probe, and move up. But we can show you that better when we do hands-on stuff.
Yeah, a bit this way around. All right.
Looks like Mark's got a Guinness there. Is that Guinness, Mark?
Yes, please. Good fun. All right, and let's see Solidus coming into view here now. Just sitting under the Achilles. And everyone's is in a slightly different place anatomically as well, of course.
Yeah. So Solidus really difficult to call on ultrasound, and they don't recommend calling stuff on ultrasound simply just so the appearance of the Solidus is so mixed. So I think they recommend MRI for that. But if you can, if you see one,
you can kind of pick up where the muscle begins and muscle belly begins and where it goes to.
And actually, just while you're there, let me just increase the depth a little bit. Okay, and I'm just gonna.
And you see that?
I'm just gonna move my big toe. There's flexor hallucis underneath there. You can see that moving nicely.
Lovely. Very cool.
Oh, let's see. I'm not really. There we go. Moving the focus down. Get everything right. So we've got tendon, Solidus, Achilles tendon, Solidus, and flexor hallucis all in one image there. Nice.
Nothing like playing around with ultrasound.
I'll just prompt anyone else. Have we got any questions? Mark's actually on the Coke, not the Guinness.
Oh, yeah.
We believe him. Yeah, cool. All right. I'll just while we're here, I'll just go over the anterior ankle then. Let's just have a little butchers in there, see if there's anything lurking around. Nice little muscle there. What's that dark patch? Okay, so there's the ankle recess. I'll just get Adrian to flex his ankle. Could probably adjust your image a little bit here. Get deeper into it.
My bad.
You can see the extensor tendon sitting over the top of the image. A bit of paratino. Is that a blood vessel under there?
Yeah, just here. So let's
quite unusual.
Let's put the colour on there.
You could think if this is you could think that was a little cyst on the anterior ankle.
Yeah.
So of course you've got to put a box on there to see if it's made of anything. Is anything flowing through there?
Bring the scale down. Let's see. It's going to get very blurry.
Put up the ends of the image, so we've got the tendon going all the way across.
There you go.
So let's see if we can squish it. You see, you can't quite squish it because I can't get pressure on it enough. All right, there you go.
Yeah.
Actually squish it right away.
Yeah.
I'll let it come back again. So again, if it was a cyst or ganglion or whatever, anything soft tissue lesion, you wouldn't really be able to do that to it. Let's see.
Yeah. And of course, if you go longitudinal, a cyst won't elongate out.
That's kind of long axis there. Good trans on it. You can just see the tendon above in transaxis.
Yeah.
Nice halo around it, but yeah, nothing that way. There you go.
There you go.
A bit of vessel here.
So I'll just put the colour on because I can reach that one.
Lovely.
Okay, now actually, here's a classic example of your red toward, blue away. Your probe is on the top here. Let me get the. Your probe is up here. Okay, so red is coming towards the probe, and then this is going away from the probe, so that's blue. So it's the same vessel. Probe's up here. Red toward. As it goes back. There's a period where you get 90 degrees and you don't get any flow, because obviously you've got to have a Doppler angle. You've got to have some sort of angle to give you the colour flow. That doesn't work in power, obviously, because it's independent direction. But with this, you'll have a period red toward, going towards, no flow because there's no Doppler angle, going away, and it goes blue. There you go, that's a good example.
There you go, hope that clarifies things a little bit further.
Brilliant. Thank you.
Just
see if you've got any other questions. Mark's quite rightly pointed out it's cola, not Coke. That could be
Yeah, don't want to
cola. Now it's cola. That brings me on to the K sketch, but we won't do that tonight.
Yeah, we'll just head down the
Mum's cheap cola.
Apparently, it takes 35 glasses of water to flush out 1 can of cola.
Is it really?
Is that right?
Good Lord.
Well, I love this stuff. So we're just looking through the mid-tarsal joints here. We're just looking at nice joint spaces. You know, you've got clean edges to the bones. You can't see any osteophytes. You know, you can make out the cuneiforms there. They go down as far as the first TMTJ. Right there. And your metatarsal. There's a nice image showing the dorsal bones of foot. You can see the tendon over the top. That's the helicis. And put it into transverse axis. We'll pick up a bit of dorsalis pedis there somewhere. There you go. It's a bit more difficult because, of course, the dorsum of the foot's kind of quite contoured and your probe's not. It's just straight and flat, so you have to kind of roll around and over it. We'll pick up some vessels there. Do you want to flick on your little Christmas lights?
So I'll put the colour on. Artery in the middle.
Lovely. Nice.
And the names either side. So obviously you get the pulsatile with the artery. So yeah, I mean you won't need this for MSK necessarily, but let's just put. There you go. Arterial. Obviously you can adjust it. I've got the scale not right there, that's why I'm getting, but you can see the arterial pulse. And then venous. Just turning, going up. I'm not getting much there at all. But anyway, no arterial flow.
Got a couple of questions actually, but see the screen, or can you see the questions?
No.
Okay. John's testing me.
Yeah.
Testing my terminology and what have you. But before I go on to that, John, I've got a question from Mark. Do you use the hockey stick much? And if so, when? I think this came out the other week, didn't it?
Well, the hockey sticks
the
are
probe
great.
you got there is a smaller footprint than typical for a limb.
Yeah, the hockey stick's a really good probe, especially if you're doing things like rheumatoid assessments for the small joints, because it's a smaller footprint and it's shaped like a pen if you like, well, a hockey stick. That's what really. So you can hold it like a pen and you can manipulate it very easily around the small joints. So really good for rheumatology.
Yes,
I've got one that I use for rheumatology, but you might not have access to it. But if you're doing little small joints, then it's really good.
yeah, they're nice.
Abid, have you got the standard linear there, the 741 in the clinic?
Yes.
Can you just hold those two probes up, the one for the audience? So you've got the 12 lb that's in Adrian's hand that he's been using this evening. Have you got the standard linear probe there as well?
That's the only one we've got here this evening.
Oh, so the 741 typically is the standard one.
This is good all range, isn't it? I think you can do most MSK stuff with that.
Yeah.
I've never had a hockey stick in my practice. How long have I had ultrasound scans for? About 6 years.
Yeah.
And I've always managed very, very comfortably with one of those.
With the linear,
I'd love to have a hockey stick. I think it'd make it a lot easier. But I think if you can get around stuff with that, you can do anything anyway.
Well, that's the interesting thing. That 12 lb that you've got there now, it's a relatively new one to the range, and it performs like the linear probe, but it's got a smaller footprint. That's what I was going to say. Two there, we could put them together.
And put my hand next to it, you can kind of get an idea of the footprint there.
Yeah. So it's a real improvement actually on the probe range. I
found it absolutely fantastic to get around most of the foot and ankle stuff.
Yeah.
In Adrian, at least. I'd probably like the hockey stick probe more if I'm doing guided stuff, just because it's smaller and lighter and a bit easier to handle. It's a bit more, easy to do. But I manage absolutely fine with this size probe and have done for a long time now. So, but yeah, the hockey stick's great.
Okay, I've been putting this question off for long enough, so bear with me, everybody. I'll take you all off mute and I'll hear you laughing. How does one image the os trigonium and the os steda process of talus? How did I do?
You can. I don't know about the os steda, but the os trigonium you can if you've got good depth. I mean, usually you do an X-ray for that, but you can look at it if you go at the back of the heel. If you go back to underneath the Achilles, you don't usually get asked this because it's usually X-ray, but you could
you can make it out.
You can make it out, but you need to get your depth right down. Sorry, depth right up
the steda process, not the os steda. Actually, a correction to the question.
So, so this is where I'm going to take the TGC to emphasise the very deep image. So it's down here somewhere where you see there. So this is where you pick up the os trigonum.
Well, it's going fairly deep there, isn't it?
Yeah.
Can you see how the ultrasound probe is like a torchlight, just shining kind of into that area?
So if you see a little osteophyte or little bony thing off here, that'll be your os trigonum. But as I say, that is usually X-ray that they use for that. But you can pick them up incidentally, probably.
It is great for bony detail in the foot. I can often see much more than I can on X-ray, to be honest, especially with the smaller joints in the foot and through the midfoot. And quite often you'll get normal looking midfoot tarsometatarsal joints, but you can see a really different picture on ultrasound, isn't it? You get really bad osteophytic changes and calcific things floating around and whatnot. Yeah. You just can't see it all on X-ray.
Yeah.
I'm sure it's probably similar for the small joints of the hand,
yeah, absolutely.
Shoulder and other things, so it's very interesting.
Well, ultrasound's taken over now. X-ray for subclinical synovitis of the, in the hands and joints. You'll see little erosions and synovitis before you see the erosions on X-ray.
Blood vessel there for you guys. That sounds pretty good. All right. How are we doing for time then?
Well, it just turned 9 o'clock.
Awesome.
Not got any questions coming at the moment. We can
tailor dome with your ankle.
So you look for little osteophytes there. Chondrial calcinosis, gout.
Anterior ankle tendons, and then the tailor dome is all in one in that picture. The image, and that's just by adjusting the depth that bit. Adrian's got a really nice image there. Look at that. Textbook stuff. Do you want to just flex your ankle a little bit for us there, Adrian? Oh, lovely. Makes my day.
No, you spent
Beautiful, beautiful image. Lovely.